One of the biggest fears in caring for extremely premature infants is intraventricular hemorrhage, or IVH. The difficult part is that it can happen without any obvious warning signs. The good news, many of the things we do every shift are specifically designed to reduce that risk. Today, we're going to connect those bedside interventions to what's actually happening inside the baby's brain. In this video, we will talk about what IVH is, why preemies are at such high risk, the interventions NICU nurses can do to reduce this risk, and a very important fact that we all need to know. Let's dive in. What is IVH? IVH stands for intraventricular hemorrhage. So an intraventricular hemorrhage is simply bleeding into or around the fluid-filled spaces inside the brain, called the ventricles. To understand why this happens, let's take a quick look at the anatomy of a premature baby's brain. Inside the brain are four connected spaces called the ventricles. These ventricles are filled with cerebrospinal fluid, or CSF. This clear fluid cushions the brain, delivers nutrients, removes waste products, and helps maintain a stable environment for that developing brain. Just next to the ventricles is an area called the germinal matrix. During fetal development, the germinal matrix acts like a construction zone for the brain. It's where many of the brain's future neurons and support cells are produced before they migrate to their final locations. Why is it so fragile? Because the germinal matrix is growing so quickly, it's packed with tiny blood vessels. But these vessels are very different from the stronger blood vessels found in older infants and adults. Their walls are incredibly thin, and they're not fully supported by surrounding tissue, and they don't tolerate sudden changes in blood flow very well. Imagine watering a newly planted seedling with a fire hose. The pressure would overwhelm those delicate stems and crush it. In a similar way, rapid changes in blood flow or blood pressure can place stress on these fragile blood vessels, causing them to rupture and bleed. When one of these blood vessels breaks, blood leaks into the surrounding area and may spread into the ventricles. Depending on how much bleeding occurs, the hemorrhage can range from very small to much more significant. Now you might be wondering, if these blood vessels are so fragile, why don't all premature babies develop IVH? The answer comes down to one key concept: cerebral blood flow. Understanding how blood moves through the premature brain explains why so many of our daily nursing interventions are focused on keeping these babies as stable as possible. Now that we know what an intraventricular hemorrhage is, the next question is, why does this happen almost exclusively in premature babies? The answer comes down to one key word: immaturity. The earlier a baby is born, the more immature every organ system is, including the brain and its blood vessels. Remember that germinal matrix we just talked about? It's most prominent in extremely premature infants because it's still actively helping the brain grow and develop. As pregnancy continues, this area gradually disappears as brain development progresses. By term, the germinal matrix is almost completely involuted, which is one of the reasons IVH becomes much less common in full-term babies. The blood vessels within the germinal matrix are incredibly delicate. Their walls are thin, they have very little structural support, and they aren't as strong or resilient as the blood vessels found later in development. But fragile blood vessels are only part of the story. Premature babies also have an immature ability to regulate blood flow to their brains. Think of it like cruise control in your car. Even if your blood pressure changes a little, the blood vessels in your brain automatically adjust by narrowing or widening just enough to keep blood flow relatively constant. This helps protect the brain from sudden increases or decreases in blood flow. In extremely premature infants, the system isn't fully developed. Instead of keeping blood flow stable, their cerebral blood flow often changes right along with changes in blood pressure, oxygen levels, carbon dioxide levels, or anything else affecting circulation. Continuing with our garden analogies, imagine trying to water a delicate flower with a garden hose while someone keeps turning the faucet on and off. The pressure constantly rising and falling. That's similar to what these fragile blood vessels experience. When blood flow suddenly increases or suddenly decreases and then rapidly returns, those tiny immature blood vessels become overstressed. Eventually, one may rupture, leading to an intraventricular hemorrhage. So IVH isn't usually caused by one single event. It's often the result of repeated fluctuations in cerebral blood flow, acting on blood vessels that simply aren't mature enough to tolerate these changes. This brings us to one of the most important concepts in caring for premature infants. If unstable cerebral blood flow contributes to IVH, then our goal as NICU nurses is to create the most stable environment possible. In the next section, we'll talk about why the first 72 hours after birth are considered the highest risk period for developing IVH, and why so many of our interventions during that time are focused on protecting the brain. The first 72 hours after birth are considered the most critical period. In fact, the majority of intraventricular hemorrhages occur during these first 3 days of life. Think about everything a premature baby experiences immediately after birth. Just hours earlier, they were in a womb, warm, quiet environment where the placenta was doing all the work of delivering oxygen and nutrients while maintaining remarkably stable circulation. Then almost instantly, they're asked to adapt to life outside the uterus. Their lungs now have to exchange oxygen. Their heart has to reroute blood flow. Their blood pressure is changing. Their oxygen and carbon dioxide levels are constantly being adjusted. Their temperature has to be maintained. And they're beginning to undergo necessary medical interventions to support these changes. For a full-term baby, these transitions are usually well tolerated. But for an extremely premature infant, every one of these adjustments can cause changes in cerebral blood flow. Remember, these babies have two major challenges. First, they have fragile, immature blood vessels within the germinal matrix. Second, they have immature cerebral autoregulation, meaning their brains can't consistently keep blood flow stable when the rest of the body is changing. When those two things are combined with the physiologic instability that naturally occurs after birth, the risk of bleeding is at its highest. It's also important to understand that IVH usually isn't caused by one single event. It's rarely something as simple as one diaper change or one blood pressure reading. Instead, it's often the result of repeated fluctuations in cerebral blood flow over time. Think of it like gently bending a paperclip. One bend probably won't break it, but repeatedly bending it back and forth eventually weakens the metal until it snaps. In a similar way, repeated fluctuations in cerebral blood flow place ongoing stress on those fragile blood vessels within the germinal matrix, increasing the likelihood that one may eventually rupture. The encouraging part is that many of these fluctuations can be minimized. That's exactly why so much of our care during the first 72 hours is focused on creating stability. Nearly every intervention we perform, from positioning the head to midline, to clustering care, to maintaining temperature, to carefully managing ventilation, is designed with one goal in mind: protecting the developing brain by minimizing unnecessary fluctuations in cerebral blood flow. So we've talked about fragile blood vessels, immature autoregulation, and why the first 72 hours are so important. But what actually causes cerebral blood flow to change? The answer is that almost anything affects a premature baby's overall physiologic stability can also affect their blood flow to their brain. Let's start with oxygen. The brain is one of the body's largest consumers of oxygen, so it constantly adjusts blood flow to meet its metabolic needs. If oxygen levels drop, the brain responds by widening or dilating its blood vessels to increase blood flow and deliver more oxygen. On the other hand, when oxygen levels become too high, these blood vessels can constrict or narrow. These changes are part of the body's normal response. But in extremely premature infants with fragile blood vessels and immature autoregulation, repeated swings in oxygenation can contribute to fluctuations in cerebral blood flow. Carbon dioxide has an even greater effect on cerebral blood flow than oxygen. When CO2 levels rise, blood vessels in the brain dilate, increasing blood flow. When CO2 levels falls, those vessels constrict, reducing blood flow. This is why we pay such close attention to ventilation in premature infants. Rapid changes in CO2 can lead to rapid changes in blood flow. Blood pressure also plays a major role. In healthy older children and adults, cerebral autoregulation helps keep blood flow relatively stable, despite small changes in blood pressure. But remember, Premature infants haven't fully developed this protective system. That means a sudden drop or a sudden rise in blood pressure may be transmitted directly to those fragile blood vessels within the germinal matrix. Rapid administration of fluids or blood products can also affect cerebral circulation. While these treatments are often necessary and life-saving, they should be given thoughtfully and according to your unit's protocol to avoid sudden changes in blood flow whenever possible. Even things that seem small can have an impact. Pain, excessive stimulation, prolonged crying can trigger stress responses that affect heart rate, blood pressure, and oxygen consumption. Those physiologic changes can influence cerebral blood flow, which is why developmental care and minimizing unnecessary stimulation is so important. Think about everything a premature baby might experience during a shift. Diaper changes, temperature checks, blood draws, repositioning, suctioning, assessments. Each of these interventions is important. Every time we disturb the baby, we create another opportunity for physiologic instability. That's one of the reasons why we try to cluster care whenever it's safe to do so. The goal isn't to avoid every intervention. It's to perform every intervention in a way that keeps the baby as physiologically stable as possible. Now that we understand what causes fluctuations in cerebral blood flow, let's look at our everyday nursing care can help minimize those fluctuations and protect the premature brain. Midline positioning. One of the simplest and most important interventions we perform is maintaining the baby's head in a neutral midline position during the first several days of life. Why does this matter? Blood leaves the brain through large veins in the neck called jugular veins. When the head is turned significantly to one side, that venous drainage becomes less efficient. If blood has a harder time leaving the brain, pressure within the cerebral circulation can increase. In a premature infant with fragile germinal matrix vessels, that additional venous pressure may contribute to the risk of bleeding. Keeping the head in a neutral midline position helps promote unobstructed venous drainage and supports more stable blood flow. Gentle handling. Premature infants don't tolerate rapid changes particularly well. Quick movements, frequent repositioning, or rough handling can trigger changes in heart rate, blood pressure, oxygenation, and overall physiologic stability. We need to be moving the baby's body slowly during repositioning and avoiding unnecessary stimulation whenever possible. Every movement should have a purpose. Another important strategy is clustering care. Rather than disturbing the baby every 15 or 20 minutes, we try to combine necessary interventions into one care period whenever it's clinically appropriate. For example, during one care time, you might complete your assessment, change their diaper, obtain a temperature, reposition the baby, and collect any scheduled labs. Then the baby is allowed a period of uninterrupted rest. This decreases repeated stimulation and reduces the number of physiologic fluctuations throughout the shift. We've already discussed how oxygen and carbon dioxide affect cerebral blood flow. That's why maintaining stable respiratory support is so important. Avoiding prolonged desaturations, minimizing large swings in oxygen levels, and preventing unnecessary changes in ventilation all help reduce fluctuations in cerebral blood flow. This also highlights the importance of preventing accidental extubations whenever possible. Reintubation can expose these infants to significant physiologic stress, so careful securement of the airway is another way we help protect their brain. Temperature regulation is an important piece of the puzzle. When a premature infant becomes cold, their body has to work much harder to stay warm. Oxygen consumption increases, metabolic demand rises, and overall physiologic instability can follow. By maintaining normothermia through appropriate incubator settings, humidity, warm linens, and minimizing unnecessary heat loss, we're helping reduce those additional physiologic stresses. Preventing IVH isn't the responsibility of just one person either. It takes a team. Nurses, respiratory therapists, neonatal nurse practitioners, physicians, pharmacists, and every member of the NICU team play a role in creating a stable environment for these babies. Whether it's coordinating care times, communicating before repositioning an intubated infant, or carefully planning procedures, teamwork helps minimize unnecessary instability. Instead of memorizing a checklist, think about this question. Will this intervention help keep cerebral blood flow as stable as possible? If the answer is yes, you're helping protect the brain. I want to talk about something that's just as important as everything else we've talked about so far. That despite all of our best efforts, not every intraventricular hemorrhage can be prevented. We've talked about the many things we can do to reduce the risk: keeping the head midline, clustering care, maintaining stable oxygenation and ventilation, and practicing gentle handling, as well as creating the most physiologically stable environment possible. These interventions are evidence-based and absolutely matter, but they're just one part of a much bigger picture. A baby's gestational age, birth weight, how sick they are at birth, infection, respiratory disease, cardiovascular instability, the need for resuscitation at birth, and many other medical factors all contribute to the overall risk of developing IVH. Many of these factors are also completely outside of our control. We can't change how early a baby was born. We can't erase the physiologic challenges that come with extreme prematurity, and we can't eliminate every risk. What we can do is provide thoughtful, evidence-based care every single shift. We can anticipate problems before they happen. We can communicate with our team. We can move with intention. And we can make every decision with the goal of keeping the baby's brain as stable as possible. If you're a new NICU nurse, I just want you to remember this. Caring for these tiny patients can feel overwhelming at times. There are so many details to think about, and it's easy to worry that one mistake could cause harm. The reality is that IVH is a complex condition with many contributing factors. Your role isn't to control everything. Your role is to provide consistently safe, evidence-based care while you're working closely with your team. Every time you keep a baby's head in midline, every time you cluster cares, every time you successfully communicate before turning an intubated infant, every time you slow down and handle a baby gently, you're helping reduce unnecessary stress on an incredibly fragile brain. Those small decisions add up. The goal isn't perfection. The goal is stability. Because while we can't eliminate every risk, we can create an environment that gives these babies the best possible opportunity to grow, heal, and thrive. Let's finish by reviewing the 3 biggest ideas I hope you take away from today's video. Intraventricular hemorrhage is one of the most serious complications of extreme prematurity. But understanding why it happens helps us understand how we can help reduce the risk. First, remember that premature infants have fragile, immature blood vessels within the germinal matrix. These vessels simply aren't built to tolerate large changes in cerebral blood flow. Second, during the first 72 hours after birth, these babies are going through tremendous physiologic changes while their brains are still developing. That's why this period requires such careful attention to maintaining stability. And remember that almost every nursing intervention we've discussed has the same goal: maintaining stable cerebral blood flow. You're helping create the most stable environment possible for a developing brain. And remember that all of those small, thoughtful interventions you perform throughout your shift truly make a difference. If this video helped you in any way, subscribe to NICU Compass. Every video will break down another neonatal concept into something that's easy to understand, so you can build your knowledge, confidence, and provide better care for your tiny patients. Thank you so much for watching, and I'll see you in the next video.